My name is Dr. Vijay Raskina, and I'm an orthopedist with a special interest in adult hip and knee restoration and reconstruction. It's a subspecialty of orthopedic surgery that some of you may or may not know, but my focus is not only surgery but also on preserving joints that we have to give us the best outcome possible. Let's talk about what exactly is the hip. The hip is a joint between your femur or thigh bone and the pelvis. As you can see up there, it's a ball and socket joint. And what we're interested in is the cartilage. That is the cushion that we walk on every step, every day. And what exactly is the knee? The knee is a joint which is more than a hinge between your femur or thigh bone and your leg. And it's the one that you bend and straighten, twist on, dance on, and all those good things. The most important issue that we have here is the cartilage that lines the joint. That is an extremely valuable tissue that cannot regrow on its own. Once you get damage to cartilage, in spite of 50 years of research, we're still struggling to get this thing to grow on its own and regenerate on its own. And so essentially what happens in arthritis is it's a disease of cartilage wear and inflammation that results from that cartilage wear that causes all the good complaints we have. That's pain, stiffness, limping, locking, difficulty moving about, difficulty with stairs, on and on and on. That's an x-ray of a normal knee. That's the femur bone. There's the kneecap of the patella. There's your tibia. You see the space between? That's the normal cushion of cartilage that you walk on. You don't see it on x-ray, but that's the space. No need to be a rocket scientist. You see that one there? There's nothing there. That's what we call bone-on-bone arthritis. And some of you who have that, you say your knee cricks and crunches. That's because you have bone rubbing on bone. You no longer have cartilage there. So we're going to talk about your joint pain. It's everybody's problem. Anybody not had a painful joint ever in their life? No? Okay. We're going to talk about treatment options, and we are not going to talk about surgery for the first part, okay? There are a bunch of tests that you may have to encounter on your pathway with arthritis because there are various types of arthritis, osteoarthritis being the major player. It accounts for 90 to 95% of arthritic complaints that we face. And these tests run anywhere from blood tests to urine analysis to radiographs and then specialized tests like CT scans and MRI and whatever else. When we talk of non-surgical options in arthritis of the hips and knees, you can see there's a whole host of things that we can employ because everybody is different. There's no two people with the same problem in terms of either their hip or their knee, and everybody has a different combination of these factors that can be employed to attain a significant amount of relief short of surgery. So we'll go through them. Let's start with the first thing. Overemploying rest can cause deconditioning of muscles and tendons and joints and can actually reduce our mobility. So we got to use rest judiciously to let the inflammation calm down in a joint before we can then start to rehab it. And that's a basic principle that we use in terms of how we deal with arthritis. So using rest is important, but overdoing it can be counterproductive. Okay, next big issue that we have is weight and obesity. It's pretty rampant in the United States, but it plays a big role in arthritis, both in surgical and non-surgical management. So let's talk about this. How do we start with dealing with obesity? And it starts with basic ABCs, a diet. We got to change our diets, what we eat, how much we eat, how often we eat, all that good stuff. I've seen patients who've offloaded 20, 30 pounds and their knees may be bad on x-ray, but their pain's gone away. They don't need us. They can function, they're good. We watch them every year. That's fine, perfectly fine. So this is, if you want bang for your buck, it's not going to cure your arthritis, but it will improve your quality of life in more ways than one. The next thing is exercise. There are two main types of exercise that one needs to be aware of. There's the stretching exercise. That tends to get rid of stiffness. And we can do that with relatively low impact. The two areas is biking, whether it's stationary bike or an outdoor bike. And then, of course, there's buoyancy in the pool. This is a great place for arthritis because you don't have gravity working against you. You actually have the buoyancy of the water offloading your joints, so you can move your joints much better to get them eased up and moving. The other type of exercise that we talk about is strengthening. We talked about stretching, but strengthening is equally important. And the way strengthening works is normally we have muscles that stabilize our joints. And they act as shock absorbers and dampeners. When you have weak muscles and you tire, you tend to put more stresses across your joints. So some of you with arthritis may notice that if you go out shopping, the first part of the shopping episode is great, but after a point when your muscles tire, your joints start to hurt and you have to sit down. And the reason for that is your muscles have now exceeded their fatigue tolerance, and now you're putting more and more forces across those joints which are not normal. Aerobic exercise is great for arthritis in more ways than one. It's good for our hearts. We know that, it's been proven. But the other place that it's really good for is you can lose some weight, as well as it can control inflammation. So the three places where we can do that is walking. The other place that you can exercise, like we talked about, is a stationary bike. It's a great piece of equipment, and it can exercise the hip and the knee and the ankle all at one time. And the third thing is water. We talked about it. You can use water, you can avoid gravity, and attain the benefits of a reasonable aerobic exercise program. All right, let's talk about something else. How about heat and cold? So there are a whole host of things, and they go from simple stuff like a hot shower. Heating pads are available. There's infrared pads. There's these packs. You put them in the microwave, and you can apply them across your joint. They're available. In terms of heat and cold, we'll talk about what to use for what joint. Cold packs are available. You can get stuff out of the refrigerator. There's gel packs you can freeze and put them on your joints. And the way they work is they tend to reduce inflammation. Now, there's a common question that gets asked is, what should I use? I'm going to give you a rule of thumb, but there's an exception. In terms of back pain and hip pain, heat tends to work, in my experience, better than cold. In terms of knees, 80% of patients that I talk to feel that cold compress and ice tends to work better. Okay, anybody been to physical therapy? It's an important component, and the physical therapists work in more ways than one. They not only work with you individually, but you get to interact with people who are going through similar issues and how they deal with it. And so that can help too. But the way it really works is they teach you the right technique of doing the exercises. Okay? They can also help you in terms of how to use things like canes and crutches and walkers and whatever else, so that you don't stumble and fall and injure yourself. So they're able to gently use modalities in order to stretch your joints out. If there's stiffness, they can overcome that in a sequential fashion. But at the end of the day, they do play a very important role, and one needs, if you're going to do physical therapy, one needs to supplement it with an exercise program at home in order to maintain the benefit. Assistive devices is the next place where we can employ physical means to reduce stresses across the joints. Overall, the ones that we're familiar with are the canes and the walkers. Okay? And there are some fancy ones nowadays that, short of a motor, they've got a seat and they've got a handle and they've got a shopping bag and all that good stuff. Let's talk about drugs. The ones that reduce inflammation go under a category known as non-steroidal anti-inflammatory drugs, NSAIDs. You might have heard of them. And they go anywhere from aspirin, Advil, Aleve, that's the trade names for them, to the Aleve is naproxen. So these are over the counter. And then you have the more modern anti-inflammatory medications. Some have come and gone. Some of you have used Vioxx, may or may not have. It's out of the market now. You have Celebrex, you have Mobic, you have a whole host of other anti-inflammatory medications. There's no one single magic pill. Some of them work with some don't, so you just got to figure out what works best for you. Then there's other medications that we can apply topically on the joints. And there's two types. One is counter-irritant medications like Icy Hot, which irritates the skin, and so it causes a burning of the skin and tends to take away the pain from the joint by a clever mechanism. And then there's prescription medication, which is the Voltaren gel, which is an anti-inflammatory some of you have used. It's essentially a non-steroidal anti-inflammatory medication in a topical form, so it gets absorbed into the local joint area and it can produce some anti-inflammatory effect. Okay, anybody take nutritional supplements? Yep, quite a few of you. Glucosamine and chondroitin sulfate are the two main ones. There's MSM out there as well. Some people do, some people don't take it. They do not cure arthritis. Okay, that's the first thing. They provide nutrition to cartilage that's left in your joint. If you have bone-on-bone arthritis, the likelihood it's going to work is small because you don't have enough cartilage for the thing to work on. Okay. The second thing is that they do have an anti-inflammatory effect. We don't understand it clearly, and I've seen patients who get on this stuff and then they get off the Aleve and Advil and all that other good stuff. There are other host of dietary supplements, and they come in various forms. One has to be careful of these things because they're not regulated. That's the first thing. The dosage strengths in them is variable based on the preparation, based on the manufacturer. They have side effects of their own, and they can trigger allergic reactions. Most of us take some medication, and these things can interact, especially if you take blood thinners for your heart and arrhythmias and things like that. These non-prescription, over-the-counter medications can put those things out of whack. And so one has to be a little careful of what you take and how much you take. You walk down the aisle and you see a whole host of things. None of them have been proven. Remember, they don't cure arthritis. Hopefully, they'll reduce inflammation. In early stages of arthritis, they can help, but one has to be a little cautious of how much you take and how you combine them with your other medications. There's another group of drugs that is out there called corticosteroids or steroids. Some of you may have taken them like prednisone or various other forms. If you take them by mouth orally, they do have long-term and short-term side effects, which can include in the long-term osteoporosis, high blood pressure, and it can also put your blood sugar out of control, depending on how much you take. So you have to be a little careful with these drugs. The other way that they can be used is in topical forms and in injections. So some of you may have undergone a cortisone shot to your knee or your hip. Does work short term, does have an effect. Try not to repeat them too often because it increases the risk of an infection in your joint. The other issues with the cortisone is that it tends to reduce the immunity. So with a drop in immunity and an invasion with bacteria, you could have a chance of developing an infection in a joint, which is a whole complicated issue. So by rule of thumb, we tend to recommend that you do not repeat them more than once every 3 to 6 months. The way the cortisone works is it reduces the inflammation of the joint. Once again, it does not cure arthritis. And one of the things with repetitive injections is it can accelerate the degeneration of the cartilage that's there. So your arthritis can progress faster. So that's the other downside, unfortunately, but that's what it is. Anybody had gel injections? A lot of people know about that stuff. It's manufactured from the rooster comb. So you got to slaughter a bunch of roosters to get this stuff. But now we're able to develop it in the lab. What it does is hyaluronic acid, which is the active component of normal joint fluid, is the main constituent of these gel injections. And when you put that, it's like putting joint fluid back into the joint to provide lubrication to the joint. Now, it does work in early arthritis where there's cartilage left to lubricate. Okay? If the hinge is short and you're going to put oil in it, it's going to work. It's going to still creep. So that's one of the things that you got to be aware of. They come in two main formats. One format is a series of 3 or 5 injections where you have to get them every week. There are now newer formulations where it's 1 shot, and that's good enough for 3 to 6 months. The one downside is there are a few patients who are allergic to this stuff or can develop an allergic reaction, and the knee blows up and it looks like they've got an infection. So you just got to be cognizant of that situation. It's usually not infection, but it looks like an infection. You may need to have your knee washed out and things like that.
What is DJD?
Degenerative joint disease. All right. Some of you may have used knee braces to help your knee. Whether they really work is debatable, but if you have a big deformity, they can correct for the deformity and stabilize your knee. Some people have significant benefit with these knee sleeves, especially when the weather is cold. It tends to improve their ability to climb stairs and things like that. They can come with a support where you slide a piece of metal on the side, which can give you some more stability. But in the long run, all these braces, one has to be careful with them because what we need is God-given brace, and those are our muscles. these braces tend to decondition the muscles, and in the long term, if you use them with weaker muscles, you tend to not get the benefit. And so what I recommend is use the brace when your knee is acutely inflamed and you want to rest it, like we talked about rest in the beginning. But after that, pay more attention to strengthening and stretching your muscles so that they can provide the stability to the joint, which will give you a longer play. Okay, so we've exhausted all the non-surgical treatments. We've tried them in combinations. We've used capsaicin, we've used ice, heat, crutches, canes, walkers, adjusted our homes, anti-inflammatory medications, injections, the works. Arthritis is a slow process. It creeps up on us, one or more joints at a time. And it compromises our ability to do various things. And each of us has a different threshold of how much we're going to compromise in terms of quality of life. Okay? Now this is a big moving target. However, it's something that we now get to, and that will answer your question in a bit about when to consider total joint. I'll answer that question because it's different for everybody. So let's just get to what is a total joint replacement. In total joint replacement for the hip or the knee, we resurface, we take out all that worn out cartilage and bone, and we resurface it with artificial materials that include metal and plastic. Okay? So what we do over here is we diffuse the forces. So we no longer have bone on bone contact because we've got something else in between now. And that in itself tends to cause a significant amount of pain relief. So what's a hip replacement? As you can see here, we put a cup in the pelvis with a piece of plastic. That's the new cushion of the cartilage. We put a piece of metal, which is the stem, the femoral stem that goes inside the marrow cavity of the femur. It's like a cork in a wine bottle. You shape the bottle properly and you put the cork in and it fits perfectly well. And then you put a ball on top of it, and that's a hip replacement. So for those of you who want to see what it looks like, those are all the muscles taken away. You see this is the arthritic joint. It's pretty worn out. So we separate the two and we take out the diseased portion. You put a metal cup in the pelvis with a new piece of plastic. That's your new cartilage. There's an implant that goes inside the femoral stem, femoral canal, and you have a head on it. You put that back together, voila, you got a hip replacement. In knee replacement, it's mainly a surface operation where we're just resurfacing the joint. So we have the femur bone of the thigh here. We put a metal cap that goes at the end of the femur. You have a metal plate that goes inside the tibia, the leg bone. There's a piece of plastic here in between. That's the new cartilage that's worn out. We also have a fourth component that goes on the back. You can't see it here. It's the undersurface of the kneecap. So we keep your patella, which is the kneecap, but the undersurface is replaced with a piece of plastic. So that's a knee replacement. So here's your normal knee with all the muscles and tendons. And here you see the bones all eroded, worn out. So we shape the bone, and then there's a metal cap that goes on the end of the femur like so. There's a metal plate that goes inside with a new piece of plastic. We put everything together, and that's the new knee. That's the artificial knee joint. Now, this is not a simple process. Okay, it may look nice and fancy up there, but there's a whole host of people, and there's a big team that gets involved in order for you as the patient to get to the optimal outcome. You have the internist and the rheumatologist helping us on one end to optimize you medically for this big operation. You have physical therapists, occupational therapists, social workers, nurses caring for you before and after the surgery. And then you have the operative team. That's the orthopedic surgeon, the anesthesiologist, and all the operating room staff who have to come together. It all has got to be coordinated in order to get a quick recovery. And we'll talk about that, and I'll expand on that a little bit more. But remember, at the end of the day, our most important thing is right here, and we need to understand this person. Each one of you is different, and that's where we need to understand each one has got different issues in terms of medical complications, functional abilities, demands, social circumstances, where you live, how many stairs you got in your home, what hurdles you got to jump to get your groceries and all that good stuff. The goals of surgery are pretty simple. Number one, we are in the pain business. Any of you with arthritis, if you did not have pain, you couldn't care less, and I agree with you. This is the big issue. We get rid of this, we're able to improve your mobility and improve your joint stability so your legs don't give out under you. You don't fall. Ultimately, this is key. Improving quality of life, and like I talked about a little earlier, it's a target that is a wide target. Different people have different expectations, and we need to tailor this operation to suit those needs. When should you consider a total hip replacement or a total knee replacement? In my opinion, the answer is very, very simple. Let's eliminate all the complexity. When your arthritic pain causes significant physical, emotional, and social impairment. So the answer to the question of when you should consider it comes from you. Once you decide that you've had enough of all the other good stuff, the non-surgical treatments we talked about, and your issues in terms of physical, emotional, and social issues are significant that you would consider a major operation to get to a better place, that's the time. That comes from deep within, and that's the key. I'll tell all the patients, you have to decide first. We can advise you and we can help you, but the most important person in this whole equation is you. If you're not ready, don't do it, because you won't rehab well. This is an elective operation where you give control to somebody else, which most of you are individual, independent people who are strong-minded people. We respect that. And when that independence is compromised, the way it manifests itself is anxiety. If we're not able to overcome that, then it becomes a problem, both for you and for the team around. So that's why we have a whole program to prepare you mentally to answer the questions, to reduce the anxiety, because if you take away the anxiety element, the fear, you will then participate in the rehab to get to a recovery place which much quicker. Is there any negative side to the operation? Okay, there is no such thing as any element in human life that has no negative implications, including the water you're drinking in your hand. You drink enough of water and you can kill yourself. Food you eat every day. Is there a negative side to food? Yeah. Do we eat it? Yeah. Crossing the street. Is there a negative side to crossing the street? Yep. So everything, there's no such thing as a free lunch in this world. If you can find one of those, God bless you. There's no such thing. And the same thing with surgery. The issue that we have here, and this is the important thing that you bring up, is how can we minimize complications? Okay? If I tell you that the likelihood of a complication from a total joint replacement is less than 5%, you can say 5% is too high for me. And that is an issue. Fair enough. But you could say, I'm going to be that 95%. I'm going to be better than the 95% of people who've ever had a total joint. That's a whole different game. So this again goes back to anxiety and information. The idea of this kind of seminar is to give you that information of what support services and team is out there, because this is not something we take lightly. The worst thing we can have is a complication from a total joint, because the implications are not insignificant. So we don't take this stuff lightly. So who's this ideal candidate for a total joint replacement? There are broad categories. Very few people fit this. We know that. So that's why we've got to tailor the operation to suit you. How can we improve your quality of life? We're going to reduce pain, improve motion and function. That's the key. Immobility causes big problems. We're trying to improve and restore mobility. That's the title of this talk. That's key. If we're unable to do that, we then cannot improve emotional stability. We start getting depressed, irritated, angry, shouting, screaming, throwing things, all that good stuff. And then social well-being, our interactions with our peers, whatever that may be, bingo, tennis, dancing, golf, bungee jumping, whatever. Okay? So all these things are important and they're all connected, and we appreciate that. What's a good to excellent outcome from total joint replacement? One of the keys of this operation is we cannot make you 20 years younger. Be very clear on that issue. So you have to go into this operation with clear expectations. If your expectation is you're going to want to run the marathon after a total joint when you can barely walk, my question to people is, I've had a few patients, Doc, I'm going to be able to run the marathon, right? I said, yep, right. When did you last do it? Never. So one has to be a little careful of what our expectations are. Successful recovery 90 to 95% of the time. That's pretty good odds. However, it's bad odds if you think you're going to be in the 5%. Right? Because if you're in that 5%, it's 100% for you. So it depends on how you look at these numbers. That's why I don't like to talk of this, because you can skew this any way you want. So some people want to play sports. This is the literature of people who are motivated to do it. There's studies shown that 75% of patients participate in recreational sports after total joint replacement. However, that recreational sport is not playing for the Yankees. It's here. Reasonable expectations. Walking, swimming, singles tennis, some play doubles, some play golf, some work out in the gym. Some want to do gardening. The question is, especially some of you, can I kneel? Yes, you can kneel. Will it hurt? Maybe. But so, again, it depends on what you want to do. Impact loading, and that again goes back to what activities can I do? So my question is, what do you want to do? If it involves impact loading, where you're going to be jumping on these things, or what I call snap pivot sports, where you're turning on a dime and you're having to move, you're accelerating, decelerating, that tends to wear out the plastic. Remember, you got to the arthritic place because you wore out the cartilage, right? So you were doing something that wore out the cartilage. So if you're not careful of our activities, but I don't mean you need to be in a wheelchair because you got a total joint replacement. If you use these joints appropriately, they look after you. If you abuse the joint, it's going to abuse you. Stands to reason, simple as that. So let's talk about advances in this operation. These two operations now are very reproducible. The length of surgery is down to slightly under an hour now. More complicated situations may take a little bit more than an hour, hour and a half. That's the operating time. Blood loss, we try to reduce it so we can do it without blood now quite often. Depends on what your blood levels were to start with. Everybody's different. If you're anemic to start with, you're going to need blood. But if you're at 14 or 16, likelihood you're going to need blood is small. We now use regional anesthetics. We tend to avoid general anesthetics because that tends to cause confusion, fuzzing of the brain, nausea, vomiting, all that good stuff. We try to avoid those medications. So we do them under spinal and epidurals. So if any of you have had babies and had epidurals, you probably know the benefits of it. So we use that kind of anesthesia in order to do the operation. However, having said that, I have a lot of patients who ask, so am I going to be awake? The answer is no. We don't want you talking to us during the case. So you are asleep. You don't see or hear anything. However, we do not use general anesthesia where you have a tube down and control your breathing. You are breathing on your own, but you're not aware of pain and what's going on. You're asleep. Okay? It's like going to the bar for a few hours. Length of stay is now down. You see 3 to 5 days. In our accelerated rehab program that we have now at LIJ, we're getting patients out in 2 days. So there are various other techniques, but we have to select those patients. Not everybody is suitable for that acute rehab. If you've got multiple medical issues, a bad heart on blood thinners and uncontrolled diabetes and 2 joints that are badly involved, you're not a good candidate. So it depends, and we select those patients very carefully. We have faster recovery protocols. In the past, people with total joint replacements used to be in the hospital for 2 weeks. 3 weeks. Now you're in the hospital a couple of days, and then you can go home with home care and home therapy, or you can go to rehab for a little while and go home. We've improved pain control. A lot of people are afraid of these operations because of pain. We use a very aggressive pain protocols to control the pain so that you don't get to that point, including blocks, and I'll talk about that in a few minutes. We have better fixation techniques, so we can get you up on your feet the same day sometimes. If you're motor enough, we can get you standing and up on your feet because the implants are well fixed. They're not going anywhere. We've also improved how long these things last because we have newer materials. So now we're talking about 20, 25, 30 years in younger patients. Okay. Now remember that the total joint replacement is not going to make you live 30 years more. And durability is now getting out there, so we're now getting benefits of people getting out more and more. The biggest issue that we worry about in terms of total joint replacement is infection. I talked briefly about infection earlier, about trying to avoid too many injections because that increases the risk. The other things we want to do is to make sure your diabetes, if you have it, is controlled because that increases your risk of infection. But we take a lot of trouble to try and reduce the risk of infection. We give you antibiotics for 24 hours after surgery, but we have special operating rooms and equipment in order to reduce the amount of infection. I'll show you a picture of what it actually looks like. If you had a risk of 1 in 100, it's pretty good odds, right? So we want to bring that down to close to 1 in 400. The less the better, because that's an expensive proposition both for you as the patient and for healthcare in general. That's the operating room. We have body suits to try to reduce the infection. Looks like we come from space, but that's how we have exhaust systems, body suits, all that good stuff in order to try and minimize infection. So how about durability? Okay, this is conventional data of implants that were put in the 90s. At 15 years, 85% are functioning well. Of those 15% of patients, more than half of those patients aren't alive for natural causes. That's nothing to do with the total joint. So, but there are a few patients who will require surgery because their joints wear out. And that's a whole different game. It's revision surgery. We won't talk about that right now. But as the longer the joint is out, it's going to wear. It just stands to reason. But the goal of nowadays is to get it out to 25 to 30 years. Hopefully not doing this, but getting out there is what we're trying to do so that we can give you a longer durability of these joints. This is one of the articles in The Lancet, which is one of the interesting medical journals out there, which has some pretty good data, that hip replacements and knee replacements are probably one of the best elective operations, not emergency, elective operations of the last century, in terms of what it has done for quality of life, keeping patients mobile at the cost that it really costs. So there are multiple reasons. One is a pretty high success rate. We talked about 95% success rate. There's a high reproducibility. We're able to do pretty good job on a regular basis in these big centers that we have like here. We have a high quality of function. We have people playing sports. I talked about that a little earlier. They're cost effective and they're extremely durable. So let's now go to what's new, because every year you have new things coming out, and we'll give you a brief rundown. So one of the most important things is the wear of these joints. The cartilage that you had wore out. We're trying to make these joints last 25, 30 years, if not more. We've improved the bearing surfaces in terms of getting better polyethylene in. The plastic I talked about, that cartilage, we now have much better processed polyethylenes that are lasting much longer, and they're projected to last even longer. And then we use other things like metal on metal and ceramic. There are various technology to replace metal in order to give you a longer lasting joint. So here are some pictures of what it looks like. We've improved the plastics. You have ceramic heads, which is much smoother than metal heads, so they don't wear the plastic as much. And then you have metal on metal bearings, which are like ball bearings in the car. The good side is you wear them much less. Some of you are engineers, you probably know that. But when you wear, you have metal ions, which go into the bloodstream, and normally the kidneys get rid of it. But there are some people who are allergic to certain types of metal, and we can't use them in a certain group of patients. So it depends on what your certain situation is. What's new in total knee replacement? We have better kinematics and better designs in order to address the question that we had is, can you sit on the floor, can you squat, can you do various things? So there are better designs in order to improve the bending ability of the joint in itself. We've also been able to improve the patellofemoral joint, which is the one that helps you climb stairs and do various other things. Then we have designs that have improved range of motion, which is again linked to what you're talking about, trying to bend and squat and do various other things. And we have better polyethylenes as well as better designs in terms of the polyethylene rotating. So it moves like your knee, where the cartilage moves around. We have designs that are able to do that. So here's an example of the polyethylene. It rotates as you bend, so it allows you more flexibility in terms of a range of motion. Then there's something known as partial knee replacement. Not everybody needs a total knee replacement, which is a much bigger operation. There are some of you who may be candidates for partial knee replacement. Only 10% of patients with advanced arthritis fit this category. But the benefit is it's a smaller operation. It's an individual thing. It gives you a more normal functioning knee. But like I said, only 10% of patients with advanced arthritis actually fit this criteria. And they come in various designs, and this is something that we're doing here too in terms of the partial knee. But only a smaller group of patients can benefit from it. We understand pain much better now, and we know that pain works at different levels, including the brain, the spinal cord, and the tissues. And we use what's known as a multimodal approach. So we have medications and techniques to address various parts of the pain. So that addresses the pain issue in terms of reducing the amount of pain you experience in the post-operative period. We're very aggressive on this stuff because if we can get you relatively pain-free, you're going to participate in rehab. If you're extremely painful at the operation, you ain't going to be able to get out of bed. You're not going to be able to help yourselves, right? So that's why we pay a lot of attention to trying to get aggressive control and prevent the pain hitting you rather than playing catch-up. We use epidural and spinal anesthetic in order to do the operation. So this is a cross-section of the spinal cord, and we put an injection into the area to numb the area. To numb the legs. The benefit is after surgery, this thing can last 4 to 8 hours, and it helps in terms of pain control. Other techniques that we use are blocks, nerve blocks. We use a femoral block or a sciatic nerve block, which can reduce the amount of pain medication you need to take after surgery because you're not feeling as much pain in the post-op period. Then we have other medications that include anti-inflammatory medications that we talked about. We use different doses in order to give you medications by mouth to control the pain. We use narcotics in the appropriate doses. And the other place where we are able to reduce pain is lesser invasive surgery. We have better techniques now where we're using smaller incisions. We don't cut as much muscle in order to reduce the amount of tissue damage at the surgery. If we can reduce that, you're going to have lesser of a reaction. The body's not going to react as much because it's not traumatized as much. And so we find that the pain is much less. There are a whole host of techniques in terms of hips and knees about how you do this operation with a minimally invasive technique. And I'll talk about one of the techniques that we're using right here, especially for both hips and knees. It's called the anterior approach. Some of you may have heard about it if you're researching hips, where we go to the front of the hip rather than to the side or the back of the hip. That used to be the conventional way. We don't have to cut any muscles, so we move them out of the way to get in. The problem with this operation is that it's technically more demanding, so you need to be well trained to do this stuff, and you need special equipment in order to do this because you've got to get around corners, so you have special bent handles and various other stuff in order to do this thing. Now, once we get to a point where we are making smaller and smaller incisions, we are now trying to operate blind because you can't see. Just think of it. If you don't make a big incision, you can't see what you're doing, right? A small hole, you're going to look through that small hole and try to do that. So you need a different way. You can't do it laparoscopically. You need a different technique. You need Superman to help you to see, okay? That Superman is computer-assisted surgery and robotics. It's a combination of computer-assisted surgery and robotics where we're able to now navigate exactly where we want to place the implants and burr the bone and do various things by using technology through a small opening. So we don't invade the body as much, but the other side is that we've got to be able to be sure we're in the right place in order to do the right job without injuring the tissues, especially the vital ones. So we use computer-assisted surgery where we can design where we want to put the implants, what angle, how much bone to cut, and then we navigate exactly where we want to put it, and then the computer helps us to facilitate for the loss of vision. So in terms of computer-assisted surgery, the question is whether it's an evolution or a revolution. That's open to debate. This technology is relatively new. There's no long-term results. So if you're going to ask for 20-year results of computer-assisted stuff, you'll have to come back in 20 years and we may talk about it. So this stuff is relatively new. It's being tested and we're using it and trying various things in order to do it. But again, technology advances at a rapid rate. That's a laptop computer of 30 years ago. I don't think many of you got a computer that's that big, right? So technology will improve. We're going to get better, faster, quicker, all that good stuff. But it comes at a cost and a price, and it takes some time to develop this technology. So in summary, total hips and total knees are one of the better elective operations of the last century. Our aim is to improve quality of life by addressing your pain, your mobility, getting you up and moving. We're trying to get you back to almost full function. Like I said, we cannot make you 20 years younger, but we can get you moving much better than you were doing at the present time. And it's fairly cost effective. I talked about the rapid recovery protocol a little earlier, and it includes a completely different team approach, which is much more aggressive. We've got to select the proper patient for this stuff. Not everybody will benefit from the rapid recovery protocol. We're going to do this procedure with all those clever techniques, the minimally invasive computer-assisted robotics. We're doing that. We have implants which are designed for higher function, people who are really going to push the envelope in terms of joint replacement. And of course, the aggressive post-operative management. We have a new concept that we're introducing here called prehab. It's pre-rehabilitation. So we're getting the physical therapist to teach you various stuff on the front end, improve your muscle strength before the operation so you can get a benefit on the back end. So we have a preoperative class which is mandatory for all our patients like I talked about. We also have you going to pre-testing where the anesthesiologist checks to make sure your heart, your lungs and all that good stuff is functioning well. But we also have this third component now which is prehab, where we are going to be focusing on learning about you in your home or wherever you live so that we can tailor the program to best get you to where you should be. So once again, like I talked earlier, it's a team approach. The most important person is you. If you're not ready for this stuff, the rest of the team is decoration. All this other stuff becomes important once you have this important person ready to go. Thank you.